Good afternoon, everyone. Okay, so it's my honor to present today a key lessons from adult data to improve the diagnosis and treatment of the children with the portal hypertension. So starting with the definition of the clinically evident portal hypertension, it's classified into three types: definite, and possible, and absent. So indefinite, they have both of the clinical findings, such as splenomegaly and low platelet thrombocytopenia, and at least one of the complications such as ascites or endoscopy evidence of esophageal varices. For possible finding, absent of the manifestation, with only findings such as splenomegaly or low platelets. And if none of these are present, portal hypertension is absent. So Dr. Jean Miloston presented in the last assault an non-invasive assessment and risk stratification of the portal hypertension in children, and her objectives was to review techniques and diagnosis of the testing for evaluation of the portal hypertension in children and how we can use these to inform management. So this slide summarizes many non-invasive measures for portal hypertension and how we apply it with in pediatric and adult with strength and limitations. So, So such as splenomegaly, blood tests like platelets, hyaluronic acid, type 1 collagen, fibronectin to detect early fibrosis, fibroscan, and MRI and CT, and finally novel biomarkers, which is an emerging area now, but unfortunately no data applied for adult and pediatrics. So in this slide, we can see the combined of liver stiffness measures and spleen size and platelets, which improves improve the curve and give the superior measures, which indicate a good markers for predict clinical significance portal hypertension in adult compared to the single parameter alone. So in this practical guidance, this algorithm provides a non-invasive approach to risk stratifying clinical significant portal hypertension. And this algorithm primarily based on liver stiffness measures and platelets count. So on the left side, when we have liver stiffness measured less than 15 with a normal platelet here, there is no evidence of clinical significant portal hypertension. But if the platelet drop less than 150 and liver stiffness evidence more than 15 with a normal platelet, this indicate the situation here need more testing and patient need more further evaluation such as MRI, elastography. But if the platelet less than 150 with the high with high liver stiffness measures more than 25, this a clear diagnosis for clinical significant portal hypertension, and patient need clinical management and surveillance and treatment for portal hypertension. So in this graph, we can see how the liver stiffness improves the prediction of the clinical significance portal hypertension in adult. So when we use a Baveno 7 criteria alone, we can see a huge gray zone area around 50% of the patient. But when we add the spleen stiffness to the Baveno 7 criteria, the gray zone decreased to 35%, which indicate a good diagnostic accuracy. So what data we have to assess risk in children? So splenomegaly, spleen size in pediatrics seen only in 24 to 100% of the patient with a portal hypertension, because there is some of the patient they have congestion or structural abnormalities. So we are not relying for screening with the spleen size. In contrast to the adult, usually the splenomegaly indicate chronicity and disease severity of the portal hypertension. So in this graph, this work done by Dr. Miloston and her group, they evaluate the platelets and liver stiffness on elastography to predict the survival in pediatrics. So we can see here in the left side of the graph, if the liver stiffness above 15, the patient have poor survival rate compared to the rest of the patient. Also, on the right side, they have similar pattern if the platelet less than 120. So in general, if we have liver stiffness above below 15 or platelet above 20, this is a good indication for survival rate. Also, in this slide, they compared a non-invasive tools for prediction of varices in children. They compared the children with the two groups, the children with varices or without varices. So they found that the platelets count and the spleen size have good correlation with the varices compared to the non-variceal group. In this study published in JBGN in 2022, and the aim of the study was to screen pediatric patient with a portal hypertension for clinical significance varices. The patient number 150 patients aged between 6 months to 18 years, and they reviewed the patient with a chronic liver disease and with non-cirrhotic portal hypertension, and they used a splenic stiffness measures and also liver stiffness measure for assessment. So as a prevalence before the study, 53% of the patient, they have varices and with a chronic liver disease, and 73% of the patient, they have varices with non-cirrhotic portal hypertension. So the result was the splenic stiffness measures is the only independent predictor for a clinical significance varices. And they have improved in the predictors from 53 to 84 in chronic liver disease and from 73 to 87 in non-cirrhotic portal hypertension. So the conclusion is spleen stiffness is the most optimal non-invasive method to screen children with a chronic liver disease and non-cirrhotic portal hypertension for clinically significant varices. AASLD does have guidelines in pediatrics, and they summarize non-invasive imaging in children with a fibrosis with different modality of the fibroscan. So here we can see the different disease like biliary atresia, NASH, or hepatitis C virus. They use different modality of the fibroscan, and all of them, they have a good result with the good diagnostic value with around the value between 0.8 to 0.9 the result. So overall, this study supports the use of the non-invasive imaging as a reliable tools for fibrosis and assessment in children, while acknowledging that performance of varices by disease and fibrosis stage. So what is the invasive assessment and risk stratification for portal hypertension in children? So here we can see the image of the hepatic vein pressure gradient, which is calculated by the difference between which hepatic vein pressure, which is reflect the sinusoidal pressure and free hepatic venous pressure, which reflect the systemic venous pressure. And it is indirect measure of the portal venous pressure. The disadvantage is invasive procedure, use of the contrast and radiation, and misdiagnosis of the non-cirrhotic pre-sinusoidal portal hypertension because the wedge pressure will be normal. So hepatic venous pressure in children, this study, they publish a paper, and they correlated between hepatic venous pressure measurement, and they correlated with the histopathological findings. So in this table, we can see in the left side, there is no good correlation between hepatic venous pressure gradient and the fibrosis finding, and even the B value, it's not significant here. On the right side, we can see they correlate also with the hepatic venous pressure gradient with many complications such as ascites and splenomegaly. Also, the B value not significant. So in summary, adult hepatic venous pressure threshold should not be directly applied to the pediatric patients. So this is a new technique, endoscopic technique. It's an EOS guided portal pressure gradient. They use it's an endoscopic technique, non-invasive. they measured the portal venous pressure directly, and they can also, during the procedure, they can identify varices, and also they concurrently they can perform AUS and liver biopsy. So this algorithm, they summarize the management of the acute variceal bleeding in the practice guidance in ASSALT. So bottom line, the key messages are prevention over rescue, which is a strategic move earlier, non-invasive risk stratification, border use of the non-selective beta blockers before endoscopy, and the stronger evidence of early tips and detailed gastric varices therapy guidance. So in pediatrics, pediatric guideline in management of the portal hypertension, still basically our experience is limited because of our evidence only based on expert consensus, no large randomized control trial, and our also management also similar to the adult management. We have some special consideration in pediatrics, esophageal varices when feasible in older children, sclerotherapy for infant, and less evidence for non-selective beta blocker. So this paper recently published in June 2025 from SBGAN Portal Hypertension Special Interest Group. The result came from a questionnaire-based study from a 40 center around 21 country in the Europe. They assessed the current practice of the management of the portal hypertension, and they evaluated the patient for screening, prophylaxis, treatment, and surgical intervention. So overall, there was a variability in the management of the portal hypertension across the European countries. So starting with screening approach, 86% of the patient, of the physician, they perform as 86 of the cases of the endoscopy. However, there is no guidelines when to start the endoscopy for the children. Also, they used splenomegaly and low platelets for a parameter for screening. However, they don't have a cut limit about low platelets for thrombocytopenia. Some of the people they used less than 100 define it as a thrombocytopenia. Some of them they define thrombocytopenia below 150. For non-invasive test, around 2/3 of them, they used liver and spleen elastography, and around 1/3% of them, they used spleen stiffness. Moving to the pharmacological intervention.
2 minutes.
Moving to the pharmacological intervention, around 68% of the patient, they use non-selective beta blocker. And the propranolol, it's considered the commonest medication used, around 85%, and carvedilol 20%. And some of the patient, some of the physicians, they combine the non-selective beta blocker with endoscopy. Surgical intervention depend on the center experience, and around 40% of them, they used surgical intervention such as TIPS and mesorex shunt. So in general, even among experience in European centers, this is markedly a variable in the when to screen for varices, when and how to use primary prophylaxis, non-invasive parameters, and when to use non-selective beta blocker endoscopy or surgical interventions. Finally, I will just talk briefly about the International Multi-Center Pediatric Portal Hypertension Registry. This is a global collaborative registry collecting pediatric portal hypertension data from many centers worldwide, and the purpose is to create large-scale pediatric data to answer the questions that small center cannot answer. So this slide presented by Dr. Schneider, presented in last ASSALT 2025, and the data, and they highlight the impact of the center-specific characteristic on the outcome after the first variceal bleed. So in summary, there was a remarkable variability among the centers for the management of the pediatric portal hypertension, and there is no standard experience between them, and there is statistical approach useful for clustering, and 6 weeks mortality after first variceal hemorrhage depend on the cluster, and there is no patient factor. So home message, common practice does not equal to the evidence-based practice in pediatric portal hypertension. Pediatric recommendations were explorated from the adult practice despite fundamental differences in disease physiology or outcome. And we should remember that the children are not small adults. And moving forward, the improving outcome will require pediatric evidence collaboration and guidelines development. Thank you.